So we've talked a little bit about parathyroid gland function already with as it relates to calcium. So parathormone or parathyroid hormone regulates calcium and phosphorus. And so if we remember, parathyroid hormone pulls and calcitonin keeps, or calcitonin tones the bone. So increased parathyroid hormone will result in a higher blood calcium because it's going to increase the amount pulling from the bone. It's going to increase the amount being reabsorbed from the kidneys, intestines, etc. So it's going to increase serum calcium. I know I've said a lot, increased parathyroid hormone pulls calcium from the bone. Obviously, it's reabsorbing in other areas as well, but students are usually able to think about that, and obviously that's a big portion of where we're getting that increase in blood calcium as well. And then parathyroid hormone will decrease phosphorus because, again, remember there's that relationship, that inverse relationship between calcium and phosphorus. So again, this picture just shows you, we would expect if we have a high blood calcium that calcitonin would be released by the thyroid gland to replace calcitonin, or calcium rather, back to the bone. Again, calcitonin tones the bone and or helps keep it in the bone in order to decrease the blood calcium. And then on the right side of this picture, you see the low blood calcium, and then that's where the parathyroid hormone will be released, because that will break down bone osteoclasts and allow that calcium to be released from the bone in order to increase serum blood calcium. So hypoparathyroidism is where we have an inadequate secretion of the PTH, or the parathyroid hormone. So with that, right away you think, if there's less parathyroid hormone, there is more inability to pull calcium from the bone, or less calcium coming from the bone. So automatically with hypoparathyroidism, hopefully you can see that we're understanding that there's going to be a low calcium, hypocalcemia, and then therefore hyperphosphatemia. So those are kind of going to be the two big things with the hypoparathyroidism. But again, if you know what the parathyroid gland does, or the parathyroid hormone does, then you can learn, rather than try to memorize, that there's going to be a low calcium and then inadvertently a high phosphate. So etiology, you'll see the biggest thing, the biggest causes of hypoparathyroidism are if we are doing a total thyroidectomy or a parathyroidectomy, and or if they're having to do any radical neck dissections, like let's say for esophageal cancer or other sorts of cancers that are in the neck area, that would affect those organs in that location. So clinical signs of hypoparathyroidism, we basically just talked about how we would expect a high phosphate and a low calcium. So once you get a question about hypoparathyroidism, or after they've had a parathyroidectomy, which then they would have hypoparathyroidism, you can just think about what a low calcium or a high phosphate will look like. Again, remember, normal calcium is 8.5 to 10.5, normal phosphate is 2.5 to 4.5. So signs and symptoms of hypocalcemia is basically what you need to know or think about for hypoparathyroidism. So remember tetany, or that numbness and tingling that they might have of their hands and feet, circumoral numbness and tingling around the mouth, that's the paresthesias. Also remember low calcium, we had those other couple tests, the Chavaz and the Trousseau's. So the positive Trousseau's is where we put that blood pressure cuff on and tighten it and leave it tightened, and then they have that where their hand has that carpopedal spasm. And then Chavaz is where we tap on that facial nerve, and they would have kind of that quivering and movement around the mouth and nose area. So signs and symptoms of hypocalcemia. And again, if you need to review that a little bit more, you sure can, but that is basically what we're most concerned about. Of course, the early signs and symptoms are more the numbness and tingling of the hands and the feet, and some of that tetany before we'd have worsening. Seizures is ultimately the worst case scenario for hypocalcemia, but only if we really had a severe hypocalcemia. So here's our picture, just reminding you of the Chavaz and the Trousseau's, which would be assessments that we can do for checking for signs of hypocalcemia. So management of hypoparathyroidism is going to be to increase the serum calcium and decrease serum phosphate. So you can see how understanding what the initial physiology is very important, because our priority assessments were revolved around the low calcium and the high phosphate, and now our treatment is treating the high calcium and the low, or excuse me, our treatments are to increase serum calcium and to decrease the serum phosphate. So increasing serum calcium, they can give IV calcium gluconate. Again, especially if they're having symptoms of tetany or that circumoral numbness and tingling and those early signs. Increase calcium and vitamin D in the diet. So again, we'll want to look at a lot of the non-dairy sources of calcium, especially because the dairy portions of calcium also are high in phosphorus, so that we wouldn't want to have dairy and milk and all of that because of the high phosphorus. So non-dairy calcium, in this case, very appropriate, your green leafy, sardine, salmon, orange juice, that's fortified with calcium. And then vitamin D supplementation. So may need to stay on calcium and vitamin D supplement for life. And then decreasing serum phosphate, I just have in there, decreasing foods that are high in phosphorus, and have some of those listed besides the dairy products. A lot of the breads are high in phosphorus. And then there are medications to reduce serum phosphate. Where we've talked about this so far already is with chronic kidney disease, where they have retained phosphate and they were on these medications when they had chronic kidney disease. So aluminum hydroxide antacids or calcium acetate, those are both examples of phosphate lowering agents. So hyperparathyroidism is going to be an overproduction of the parathyroid hormone. So now we have overproduction of that hormone that is going to pull calcium from the bone. And so we really do see a lot of the bone decalcification signs and symptoms, risk of fractures, etc. The other thing is, again, as we have more pulling from the bone, we would expect the blood calcium to be elevated, and then calcium and phosphorus have that inverse relationship, so phosphorus will be low. So high calcium, low phosphorus. The other thing with hypercalcemia is to remember that we have more calcium and more concentration of that particular ingredient that could form stones, kidney stones. So calcium oxalate stones are our most common renal stone, so that might also be a possible problem for somebody with hyperparathyroidism. So signs and symptoms of hyperparathyroidism basically will be signs and symptoms of hypercalcemia and or signs and symptoms of low phosphate. So primarily though, if we look at the bullets, the third and fourth bullet here, muscle weakness, fatigue, irritability, confusion, those are some signs and symptoms of hypercalcemia. The other things that we talked about with hypercalcemia, again, were the renal stones, kidney stones, there's higher concentration of calcium and increased risk of more calcium clumping together and forming that stone. Bone pain, again, as there is demineralization of calcium from the bone, they can have bone pain and they can be at risk for increased pathological fractures because of the bone calcium demineralization. And then there might be some other, GI symptoms, and then certainly with calcium imbalances, we still also want to make the connection with cardiac, not as significant as, say, a potassium imbalance, but certainly could develop dysrhythmias if we had a significant enough high calcium or low calcium. So the treatment goals for hyperparathyroidism will be to decrease calcium and increase phosphorus. So if we give normal saline, we give fluids, that's going to, the fluid flushes might be appropriate, or increasing the amount of oral fluids, because if we drink more, we're going to pee more, we're going to excrete more in the urine. Furosemide or Lasix is a potassium losing diuretic, but also it is calcium losing. So that would be a really good way to excrete some of that calcium via of the urine as well. And just a reminder that thiazide diuretics would be contraindicated as they do not excrete calcium. So thiazide diuretics are contraindicated with somebody with hypercalcemia. For whatever reason they have hypercalcemia, and in this case it's because of the hyperparathyroidism. Phosphorus, oral or IV, so we can actually administer or give phosphorus because again our goal is to increase the amount of phosphorus. Calcitonin might be appropriate, of course, to tone the bone and to get some of that calcium back into the bone. Low calcium diet in this case will be straining all urine because of the risk of renal stones. And then also increasing mobility. Remember that weight bearing will promote bone reabsorption of calcium. So as we have weight bearing, that's going to put calcium back into the bone, and it's also going to allow the calcium that's in the bone to stay there more readily. And then again, depending on the cause and how things are going, they certainly could, the effectiveness of treatment, they may do a parathyroidectomy. Again, you can review this if you like the pictures. This one is on calcitonin, which tones the bone. So thyroidectomy information. So we do a fair amount of thyroidectomies for various reasons, whether it be a hyperactive thyroid gland or maybe a tumor that they found on the thyroid gland. The acronym BOWTIE can maybe help you remember some of the key priority assessments and interventions for somebody after they've had a thyroidectomy. We're certainly going to be assessing for bleeding, and I just want to remind you they're going to have an incision and a small, dressing over the anterior neck, but they may have drainage that will by gravity go more to the back side or the posterior. So we do want to make sure to note if we see any bleeding that is draining down towards the posterior neck. Open airway, again, if we think of the airway, the anatomy of where we're doing the procedure, and you can see the close proximity of the trachea, the windpipe, the laryngeal nerve, and the voice box, all of those things, the larynx. So we always want to make sure that airway is intact. There's going to be some inflammation and trauma in that area that could swell and cause narrowing of the airway. So we really need to pay attention to that. We do what's called a whisper test, and we have them whisper. If we have any change in voice quality of their voice, we want to really be alert. That could be a sign of laryngeal edema, and if they have that, of course, the complication would be, actual shutting off of or closing off of the airway completely. So that would be very significant. That is why the trachea set is there. We always will have an emergency tracheotomy set in the room in case we do have sudden airway closure. Again, we talked about the incision and the bleeding. Elevating the head in a semi-Fowler's position will help reduce edema. But again, you kind of have to, work with the patient. The neck should be kind of in a neutral position, not, pushed forward, not extended back, just kind of in a neutral position for comfort for them. Checking the dressing, again, on the posterior side because of gravity. And then we also want to be always thinking about what would internal bleeding look like. I may not see any external bleeding on the dressing, which usually you don't. So is that blood pressure lowering or decreasing? Is that heart rate starting to creep up? Those would be those early signs of low volume that we want to be watching for that may indicate that there is bleeding going on internally that we can't see. Again, the trach set, oxygen, suction, all of that emergency equipment available. Calcium at the bedside. You're going to notice that they're going to order an every 8-hour or every 12-hour serum calcium. Again, as soon as we take out the thyroidectomy, remember there may be inadvertent removal of the parathyroid glands, which then we don't have parathyroid hormone, and then we would expect blood calcium to be low. So we're watching for signs and symptoms of hypocalcemia. We're monitoring those labs as they are drawn. Again, watching for tetany, circumoral numbness and tingling of their hands, feet, and then also the Fostex or Trousseau's sign. Checking for laryngeal nerve damage is certainly the highest priority because this has to do with airway breathing. If they have a change in voice quality, a hoarse voice, we need to call the doctor immediately, and obviously watching for other signs of respiratory distress, respiratory effort, stridor, any of that. Labored breathing is a true emergency. They may need to take them back to surgery. It's typically the intervention that is needed. So a couple review questions. I will just go ahead and tell you the answers here, but you read through them and answer them before you listen to my audio. But the answer here is 4. The correct answer here is 3. Correct answer here is 4, Graves' disease or hyperthyroidism. Correct answer is 4. And correct answer here is 4. Correct answer here is 3. Myxedema coma, remember, is the hypothyroid crisis. And when you look at number 3, you see the pH is down, so we see acidosis. We see the CO2 is up, so again, remember, respiratory opposite, so the abnormality there is respiratory acidosis. And remember, with a myxedema coma, they will be hypoventilating. They have a decreased respiratory rate, and they're retaining CO2. So, and then a huge priority, even in 3, even if we didn't do all of that, we see a PaO2 of 78, which is certainly a high priority. The correct answer here is D. So it's talking about a patient with diabetes insipidus. Remember, with diabetes insipidus, they have a deficit or a decrease in antidiuretic hormone. So decrease in water-conserving hormone, which results in an increased urine output or polyuria. Remember, with diabetes insipidus, we think death by dehydration. And again, if you understand the physiology and that they have a decrease in ADH, then that's where you get to D2, which is administering desmopressin acetate, which is a synthetic antidiuretic hormone. The other synthetic antidiuretic hormone is called vasopressin. The correct answer here is 2, and in this case we have very serious assessment signs already noted: a temp of 104, heart rate of 128, respiratory rate and blood pressure are climbing, but right away we see that temp and pulse. You know, we don't need to further assess vital signs or surgical dressing like in number 3. We need to notify the doctor immediately, and yep, they will very likely be ordering a beta blocker, but and doing maybe some cooling blankets and Tylenol, but the most important immediately would be to notify the healthcare provider for the orders that we need for that patient. Of course, these are always really good NCLEX style questions. Which patient would you see first? So certainly number 3 is the correct answer if we think of airway breathing, again with that thyroidectomy and a hoarse voice quality or change in voice quality. We have to think of laryngeal edema, which could be life-threatening with closure of that airway. Number 1, we certainly see that temp of 94.2 and apical of 48, and we see all those vitals that are quite low and significant, but and that would definitely be the second person, but we have to choose number 3 as our very first priority. Correct answer here is number 1. So we are moving into our final gland for the unit, the adrenal gland. The adrenal gland is broken down between the adrenal cortex and the adrenal medulla. The adrenal cortex contains or has the hormones mineralocorticoids, the aldosterone, the glucocorticoids, which is our cortisol, and the androgens, which is our testosterone. So we need absolutely need a functioning adrenal cortex necessary for life, especially because of the glucocorticoid or the steroid. That one we absolutely have to have. The medulla then is our catecholamines. So if you think of adrenal medulla, we think of too much adrenaline. You can think of epinephrine and norepinephrine. Those are your fight or flight, the adrenaline. If we have a fight or flight, we have the release of our adrenaline hormones or our catecholamines, epinephrine and norepinephrine. So it's important first and foremost to know that which hormones are associated, of course, with the adrenal gland function. So I have it broken down here as well. The adrenal cortex, again, is your aldosterone, cortisol, and your androgens or testosterone. And then the adrenal medulla is the catecholamines, your epinephrine, and your norepinephrine. So we'll talk about the disorders and imbalances where we have too much or too little of these hormones. But again, initially very important to understand what the hormones do. So aldosterone, remember, is holding sodium in water and excreting potassium. Cortisol is the primary influence for glucose metabolism. So it stimulates the gluconeogenesis, the formation of the glycogen from non-carbohydrate sources. It increases protein breakdown. Cortisol helps with suppression of the immune response. So if we're giving steroids to people that have had an allergic reaction, anaphylaxis, or other immune problems, or even like a COPD exacerbation or asthma, we give them cortisol. We give them steroids to suppress the immune response. And then also cortisol, of course, assists with the stress response. So we absolutely, as very, very important hormone, we can't do without that cortisol. And then androgens, masculization. And then when we go over to the adrenal medulla side, the epinephrine and norepinephrine, again, we want to think of the fight or flight response, the promotion of vasoconstriction to increase heart rate and increase contractility when the fight or flight response is activated. Just a creative memories notebook to help you remember the hormones associated with the adrenal gland. So for disorders of the adrenal gland, we will either have hyposecretion, which is Addison's disease or adrenal insufficiency, or hypersecretion, which we know as Cushing's syndrome. And we will also talk about pheochromocytoma, which is hypersecretion of the epinephrine and norepinephrine. So we have hyposecretion in the form of Addison's disease, or we'll have hypersecretion, which the two most common and the two that we'll talk about, Cushing's syndrome and pheochromocytoma.